This video shows a macroscopic view of a human brain experiencing a system-wide metabolic power down. Standard clinical models frame menopause as a localized reproductive shutdown, but the physiological reality involves a severe neuroendocrine reconfiguration marked by declining levels and unpredictable oscillations of ovarian steroids. Consider a 57-year-old female patient who presents with a sudden onset of heightened irritability, severe cognitive fatigue, and acute anxiety. Her medical history clearly notes that a major psychological stressor occurred 2 years prior to this clinical visit. A temporal analysis of her chart reveals that this major stressor aligned precisely with her FMP. The FMP, or final menstrual period, is the clinical marker denoting the absolute end of menstrual cycles and the transition into postmenopause. Standard diagnostic models frequently mischaracterize this specific symptom cluster as a primary psychiatric disorder or the inevitable cognitive decline of normal aging. These frameworks ignore the specific molecular trigger driving her pathology. The driver is the withdrawal of 17-beta estradiol, or E2. This molecule is the predominant and most potent estrogen produced by the ovaries during a woman's reproductive years. E2 coordinates cerebral bioenergetics and neuroplasticity, functioning far beyond its role in reproduction to dictate how the brain generates the energy required for synaptic activity. Treating this 57-year-old patient requires clinicians to abandon ovarian-centric models. To resolve her symptoms, we must directly address her brain's systemic bioenergetic reset. This diagram shows a cellular cross-section of a metabolically intact hippocampal neuron. In a premenopausal brain, E2 drives the central nervous system's primary energy network by upregulating GLUT1 and fueling aerobic glycolysis. GLUT1 is a primary transport protein that actively funnels glucose across the blood-brain barrier and cell membranes. This mechanism supplies the TCA-OXPHOS energy cycle. TCA and OXPHOS refer to the citric acid cycle and oxidative phosphorylation, the efficient cellular pathways responsible for generating ATP. ATP, or adenosine triphosphate, is the core molecule used by neurons to store and transfer metabolic energy. When E2 is permanently withdrawn post-FNP, the neuron experiences immediate metabolic strain. Without estrogen signaling to maintain transporter availability, glucose utilization in the central nervous system plummets. To survive the severe glucose deficit, the brain initiates an emergency compensation mechanism. It abandons aerobic glycolysis and relies heavily on alternative energy pathways, shifting toward ketone moieties and FAO. FAO, or fatty acid oxidation, is a metabolic pathway where lipids are broken down to generate cellular energy when primary glucose sources fail. Relying on FAO carries immense structural risk. The brain compensates for the energy deficit by catabolizing endogenous lipid stores. Specifically, it breaks down the myelin sheets of its own white matter to maintain basic energy supply, deteriorating circuit integrity. This destruction operates under the healthy cell bias of estrogen action. This model dictates that introducing therapeutic estrogen to metabolically intact cells supports homeostasis and antioxidant capacity. However, if estrogen is introduced to a neural system that is already trapped in a hypometabolic or degenerative state, the hormone accelerates the cellular damage by increasing energetic demand on broken pathways. For our 57-year-old patient, the clinical manifestation of this cellular mechanism is severe cognitive fatigue. Her brain has shifted to an inefficient metabolic fuel source and is actively consuming its own white matter. The bioenergetic crisis explains her cognitive fatigue, but her severe irritability and anxiety originate from a different neurochemical pathway. The midbrain raphe nucleus is the primary center of serotonin production in the brain, and its neurons are densely populated with estrogen receptors. This graph tracks E2 levels over time against serotonin synthesis efficiency. The estradiol withdrawal hypothesis demonstrates that sharp, unpredictable oscillations in the hormone drive the pathology, rather than low absolute levels. These fluctuations directly disrupt TPH2 mechanisms. TPH2 is the rate-limiting enzyme responsible for the synthesis of serotonin in the brain, making it highly sensitive to steroid withdrawal. Ovarian hormones also act as the primary modulator for the HPA axis, providing a crucial buffer during physiological stress responses. The HPA axis, or hypothalamic-pituitary-adrenal axis, is the integrated neuroendocrine network that governs the body's physiological reaction to stress. When estrogen plummets, that buffer disappears, resulting in an unbuffered spike in cortisol. Mapping this mechanism onto our patient's history provides clarity. The major stressor she experienced at age 55 occurred exactly when her physiological buffering capacity was stripped away by perimenopausal hormone flux. These affective symptoms emerge from an estrogen withdrawal-induced neurochemical vulnerability. This frequently yields incomplete relief in this demographic. SSRIs, or selective serotonin reuptake inhibitors, are standard antidepressant medications that increase extracellular serotonin but do not repair the underlying steroid receptor instability. These neurobiological mechanisms create a central clinical paradox regarding hormone therapy. Why does supplemental estrogen reliably protect the brain and cardiovascular system in younger menopausal cohorts, while actively increasing stroke and dementia risks in older cohorts? This timeline charts the postmenopausal years, marking the final menstrual period at year 0. The timing hypothesis explains this discrepancy. The cardiovascular benefits of MHT depend strictly on initiating treatment within 10 years of the FMP. MHT, or menopausal hormone therapy, is the clinical administration of supplemental estrogen and progestogens to counter the systemic deficits of ovarian aging. Within this 10-year window, estrogen maintains endothelial function and promotes vasodilation in healthy blood vessels. Contrast this with late initiation, meaning intervention past 10 years post-FMP, or in patients over age 65. When estrogen is introduced to a vascular system already degraded by atherosclerotic plaque buildup, it can trigger adverse thromboembolic events. Returning to our 57-year-old patient, because she is roughly 2 years post-FMP, she falls safely within the optimal therapeutic window. Her baseline vascular integrity remains highly responsive to the protective mechanisms of estrogen. The timing hypothesis is the macro-level application of the healthy cell bias. Therapeutic estrogen preserves existing systemic health, meaning it must be introduced before bioenergetic failure and vascular degradation become permanent. We can now translate this biological logic into a specific assessment and treatment hierarchy to safely stabilize the patient's neuroendocrine system. Step 1 is baseline risk evaluation. The clinician verifies the patient remains within the safe 10-year temporal window, followed by rigorous screening for pre-existing breast cancer markers, baseline blood pressure, lipids, and hemoglobin A1C. Step 2 requires selecting the optimal estrogen molecule. 17-beta estradiol is preferred over E1. E1, or estrone, is a weaker estrogen variant that becomes the dominant circulating hormone after menopause due to peripheral conversion in adipose tissue. Clinical evidence demonstrates that E2 provides superior neuroplasticity and synaptic support compared to E1-heavy formulations. This split-screen diagram illustrates the physiological pathways of different administration routes. Step 3 dictates the route of delivery. Oral estrogen undergoes hepatic first-pass metabolism in the liver, increasing prothrombotic factors and elevating VTE risk. VTE, or venous thromboembolism, is a condition where blood clot forms in a deep vein, carrying a high risk of vascular obstruction. Conversely, transdermal administration absorbs directly into the systemic bloodstream, bypassing the liver entirely and establishing a safer VTE risk profile. Step 4 dictates progestogen and androgen considerations. If the patient has an intact uterus, micronized progesterone is favored to align with contemporary oncological safety data. Additionally, if the patient presents with concurrent HSSD, physiological testosterone may be considered. HSSD, or hypoactive sexual desire disorder, is an evidence-based clinical diagnosis characterized by a chronic lack of sexual desire that causes marked personal distress. By understanding the menopausal transition as a profound bioenergetic and neurochemical event, clinicians gain precise therapeutic targets. Utilizing accurate clinical timing and targeted transdermal delivery halts active myelin breakdown, stabilizes affective circuitry, and alters a patient's trajectory of neurovascular aging.